Good morning. This is Mike Pompliano for those who I haven't met at this point. I'll be giving a presentation this morning on cervical spondylotic myelopathy. Kind of a lot to cover, a very broad topic depending on where you look at it. But a brief overview, we'll be talking about some of the etiology and pathophysiology, how it typically presents in the clinic, and then what diagnostic workup is available, in addition to treatment options and kind of surgical management. So first, starting with some definitions, spondylosis is the age-related degeneration of the spinal column, both the bones, ligaments, essentially osteoarthritis of the spine. It can involve desiccation, disc bulging, height loss, osteophytes, etc. It affects 25% of people younger than 40 and up to 85% older than 60. So typically, sorry about that. I'm fighting the conference room.
Oh no.
And my computer. They're both working just a little too well. Trying not to get double noise. Okay. All right. Sorry about that. Okay. So a brief overview. You can read it there. And then the key points from this slide were just spondylosis being an age-related degeneration of the spinal column. It can affect a wide variety of people. Like I said, age-related, so it affects more people as you get older, about 85% of people over the age of 60. It's important to keep in mind that not all spondylosis is symptomatic. There are asymptomatic incidental findings on specifically MRI. And then cervical stenosis, just reduction in the volume of the spinal canal. And when you combine these two, you get cervical spondylotic myelopathy, which is the clinically significant or the clinical manifestation of the pathologic stenosis with impingement of the spinal cord. And it's important to keep in mind that this does involve impingement. If you're not seeing impingement on MRI, you either have to consider a dynamic process that's not evident on the supine static image or an incorrect diagnosis, which can be very challenging in this patient population. Myeloradiculopathy is just a combination of myelopathic symptoms with radiculopathy. So neurogenic or neurologic compression and cervical spondylosis is the result of a cascade of degenerative changes. These age-related changes can result in loss of disc height, posterior disc protrusion, enfolding of the ligamentum, facet joint hypertrophy, and osteophyte formation around the disc margins, either the disc itself or the uncovertebral and facet joints. And all of these processes contribute to the decreasing the dimensions of the canal and foramen. You can see on the left just a classic example of many of those processes. And then on the right, eventually this leads to spinal stenosis and if severe, can lead to compromise of the spinal cord. And it can, depending on which process is involve circumferential stenosis. So looking at different factors that can result in the stenosis, there's both static and dynamic factors. So static factors are most of the ones I just described. So things like disc height loss, which typically occurs ventrally first, can lead to a loss of the typical cervical lordosis, and then can also cause secondary changes through increasing the facet load, leading to facet hypertrophy and arthropathy. The annulus fibrosis is also thinner dorsally, making it easier to herniate in a more at-risk area with the spinal cord. And then you can get some patients with congenital stenosis or a smaller canal area than typical. A lot of this is just genetics and how they're born with the congenital part. There's a study from 1983 that found 40 out of the 63 patients with myelopathy had congenital stenosis. And this is definitely something anecdotally we see in the clinic frequently, so it can play a major role. There's something called the compression ratio, which we'll talk about a couple times, but it's basically looking at the sagittal diameter, the maximal diameter versus the transverse diameter, and then multiplying that by 100 to get a percentage. And that can correlate with severity of the pathologic changes. You can see a description of that right below, resulting in what's typically described as a banana cord or banana spinal cord due to the shape. You can also get dynamic compression with spondylolisthesis. Good picture below showing that the slippage, both the anterior and posterior, given the flexion and extension, can result in pinching of the spinal cord. In flexion, typically this is draped, particularly over retrovertebral osteophyte formation, can lead to compression of the more ventral aspect, and then an extension, you can get infolding of the ligamentum flavum or pinching as that more dorsal elements are relaxed. Flexion and extension MRIs have shown to increase stenosis twice as much with extension as compared to flexion. I think this is makes sense after seeing a lot of patients in clinic that complain of pain paresthesias in the morning. I think depending on their sleeping situation, a lot of patients have a little bit more extension in their neck than they would otherwise. That being said, it's not just mechanical compression that's involved. There's also compromised vascularity. There is a study showing tenting and reduced blood flow in the anterior spinal artery as well as the anterior radicular arteries, which shows emerging evidence of persistent activation of both microglial as well as macrophage accumulation at the site of chronic interparenchymal ischemia. And this is kind of a neuroinflammatory component, which has been implicated in progressive neuronal cell death, with central gray matter and lateral column showing the most changes. And that can result in cystic cavitation, gliosis, and demyelination, just called added to the site of compression. And these can be considered irreversible changes, which may explain why some patients do not recover following decompressive surgery. That's a little controversial and poorly understood topic, which we'll discuss as well. This is a pretty cool picture showing the essentially the changes that can occur with respect to the vascular formation. Baseline on the left and then a spondylotic patient on the right, showing pretty severe decrease in both the number and size of vessels, and then only minor changes in blood flow after decompression. So really can be a permanent change in that effect. So the epidemiology of this disease is somewhat difficult to estimate, though there was some consensus of studies about 1 to 4 per 100,000, depending on which one you look at. This could be very difficult just because of the inherent nature of the disease. It can often present late. It can have a mild clinical presentation, and it's frequently misdiagnosed. We'll talk a lot about the challenges in diagnosis shortly, but it's something that I've seen firsthand in clinic. And then it can have a lot of different choices with respect to management, patient-specific factors, and those can affect the treatment outcomes as well. It's important to keep in mind, too, that there's tandem cervical and lumbar stenosis in about 20% of patients, which can be both challenging on their perspective from a functional aspect, but also on our perspective as providers with respect to which to address first. The most unique feature of this condition by far is its subtle and varied presentation, and there's often an insidious onset. Patients can have an insidious onset of clumsiness in their hands as well as their lower extremities. This can present as inability to carry out fine motor movements, typically decreased grip strength, dropping items, difficulty opening jars, worsening handwriting, difficulty with buttons and zippers, as well as the diffuse numbness in the hands that we mentioned. They also may complain of urinary or urological complaints such as urgency, hesitation, frequency, but it's not typically associated with frank incontinence unless it's pretty severe disease. Also commonly represented is worsening of balance and gait instability. It can be subtle, such as needing a hand railing while going up and down stairs, or it can be a little bit more obvious, like recent use of a cane or a walker. It's very, very important to remember that pain may or may not be present, and it's a less reliable symptom. So some patients even come into clinic and they say, hey, my neck doesn't bother me. Why are you focusing so much on my neck? And I've had a couple even almost get upset that you're talking so much about their neck, but they don't even know that that's where the problem is originating from. This presentation with respect to the misdiagnosis is also very difficult because it's confounded by other factors. So yes, a patient may have decreased grip strength, but if they're having associated hand osteoarthritis, then that can be contributing as well. There's a lot of typical kind of bowel and bladder changes that happen as patients age, especially with men and BPH or females with leaking. It's important to ask about changes in that over the period of time they've been having other symptoms. So if their gait has been declining over 6 months, have they had bowel or bladder changes during that time as well? Or is this something that's been more chronic over 10, 15, 20 years? Things like normal pressure hydrocephalus are on the differential, which can present very, very similarly. And it's also important to keep in mind more central etiologies of these symptoms. There's a concept called the myelopathic hand. This was described by Ono, which is loss of power and adduction and extension of the ulnar two or three fingers, presenting as inability to grip and release rapidly with fingers. Can present through the grip and release test. Typically, a patient should be able to do that about 20 times in 10 seconds or 25 to 30 times in 15 seconds. And so having them rapidly kind of make a fist and extend their hand can be a good indication and a quick and easy exam finding in the room. Other things to look for on physical exam. So you want to start with the straightforward range of motion test. This can elicit other underlying etiologies as well as give a good indication, especially with respect to extension of their neck. This can also help with safety of extension during patient positioning for any surgical treatment that may happen. You want a thorough motor strength and sensory examination. Typically, you can see decreased grip strength as well as some triceps weakness. For balance, it's always important to watch them walk, but also heel-to-toe tandem walking, which can be typically a little declined in elderly patients, but you should be able to complete in some aspect. And then you can add a Romberg sign or Romberg's test, which is standing with your arms out straight in order to look for posterior column dysfunction. Deep tendon reflexes can be really helpful, specifically hyperreflexia. This can depend on the level of disease. So if you have thoracic myelopathy or cervical myelopathy at C7 to T1 area, you may not have hyperreflexive biceps, for example, but you also may not have any hyperreflexia if there's concomitant peripheral nerve disease. So either nerve root compression or other etiologies like diabetes or hypothyroidism playing a role. That being said, there are a couple pathologic reflexes that are a little bit more common in this presentation. Hoffman's reflex is probably the most common. And then you can have inverted brachioradialis reflex or the Babinski sign. Inverted radialis is shown there with flexion of the thumb and index finger. And then finger escape sign is ulnar drift of abduction and flexion of the ulnar two digits after they've been extended and adducted. And this is poorly understood, but thought to be secondary to weak intrinsic muscles. Your differential diagnosis is pretty broad. This is somewhat of a list, but there's probably a lot more that aren't even included on here just because of the breadth of symptoms, and then also the subtle nature makes it very difficult to assess. Probably the biggest differential diagnosis is just normal aging, and it's very difficult to tell at times. I mentioned the hand osteoarthritis earlier. Is that something that's can be easily explained, or is that something that's a little bit more insidious in onset? You can have things like ALS or multiple sclerosis, which can present very similarly, and then more severe diseases like tumor or stroke, and then normal pressure hydrocephalus. Although typically patients with that I found have had imaging of their brain and are kind of aware of it to some degree, and it's more of a how much is that playing a role compared to a secondary pathology. Diagnosis, because of the subtle and insidious onset, it requires a lot of tools at your disposal to really narrow down a diagnosis. And the diagnosis can be one of the more critical parts of the disease, given the decline over time. You can use clinical history. It's important to take a thorough history, but also a detailed one, getting very specific about some of the findings that are present. Physical examination, very similar concept. And then with respect to imaging, you have X-ray, MRI, and CT, which are typically utilized to help. AP and lateral standing radiographs with gravity can show some subtle spondylolisthesis or other spondylosis that's present. You can also get flexion and extension views for a dynamic look at underlying pathologies that may not be present on a static radiograph. With respect to MRI, it shows obviously finer detail with respect to the soft tissue, both herniations, hypertrophy, as well as port edema, specifically on T2 signal and the sagittal diameter of the spinal canal. You can also compare these findings and the kind of osseous alignment with respect to the standing radiographs for a kind of dynamic image in and of itself. It's thought that absolute stenosis was less than 10 millimeters and relative stenosis was less than 13 millimeters. And I added maybe because that may not necessarily be true. There's a lot of genetic predisposition to that, and it can vary patient to patient. So I'm not sure how good of an absolute rule that is, but it can give some good guidelines overall when looking at these radiographs. On CT, you can look at OPLL, osteophytes, facet arthropathy, And then you could also consider a CT myelogram if they're unable to otherwise obtain an MRI. This can also show the central stenosis very well. Nerve conduction studies can be utilized if there's a high false negative rate. It can be useful to distinguish peripheral versus a more central process. And then there's scoring system classifications that can help guide a diagnosis as well. On MRIs, some examples of the more specific findings you're looking for. You'll see effacement of the CSF with or without spinal cord changes. There's been a lot of studies that attempt to correlate the severity with disease or severity with prognosis, or use the MRI severity to help gauge treatment decisions. And it's important to keep in mind that this is just a clinical disease. You can see myelomalacia, which is bright on T2, though this is thought to be edema that may resolve. You can see the T1 signal that correlates with poor prognosis following surgical decompression. The compression ratio, which we talked about earlier, showing the AP versus the transverse diameter of the cord. And then there's a high rate of false positive, with 28% of patients greater than 40 having a herniation of foraminal stenosis, so something else that would affect your interpretation. With respect to the classification system, these can be used as a clinical measure of disease severity. There's two most commonly used systems, the NURIC and modified JOA. The modified JOA just translates the original JOA to be more applicable for Western countries. So it's things like using a fork and a knife instead of chopsticks, but very similar otherwise. And these can be used to provide a metric to quantify the extent, but more importantly, the progression of disease. So over time, as you're following someone in clinic, if they have a decline in their MJOA score, for example, it can be very helpful. It's typically one of the studies that originally looked at the MJOA showed a pre-op deterioration and use of both their hands, upper extremity, and gait. And then they saw weakness in the intrinsic muscles as well as triceps, which improved postoperatively, in addition to the iliopsoas and quadriceps, which improved postoperatively as well. Typically, the mild disease is considered greater than 15 on the MJOA, moderate is 12 to 14, and then severe is an MJOA of less than 12. With respect to the treatment, typically the natural history of this is considered a stepwise decline over time. It can be very difficult to predict. Again, there's a very individual nature to this whole process. Clark and Robinson looked at 120 patients with myelopathy in 1956, and they noted three typical patterns. 75% had a stepwise decline, about 20% had a slow, steady progression of the disease, and very rare, just about 5% had rapid onset of symptoms and then remained stable for years. So it's not very common to have a sharp decline following this, which is important for counseling patients in clinic. There's a study that saw 13 of 66 patients with asymptomatic cord compression develop signs or symptoms of myelopathy over 2 years, which is consistent with the previous statements, but also 13 of 66 is a relatively small number. And then they found predictors of surgical outcome being age, spinal canal, and cord dimensions, and then duration and severity of symptoms at presentation, which I think matches a lot of other findings we see in spine. This was a study looking at the natural history of 45 patients with a mean follow-up of 78 months. There was mild myelopathy on T2 with a T2 signal, and they were managed non-operatively and then kind of followed for neurologic deterioration and conversion to surgical management over time. And what they saw was about 82% were without deterioration at 5 years, and then 56% were without deterioration at 10 years. So may put a little pause in terms of counseling patients in clinic. The problem is you can't really predict who is who in that equation. They found adverse factors in an attempt to make that prediction, being large range of motion with respect to the cervical spine, segmental kyphosis, and then instability at the site of maximal stenosis. With respect to non-operative treatment, this is usually reserved for mild myelopathy. There's many patient-specific factors that can go into this decision in the more mild presentations. So symptom severity, also myelomalacia on the MRI. You can see functional levels with weakness, which may progress or may point you more towards surgical intervention. And then symptom progression over time, if they had no symptoms and then are quickly presenting with progression of neurologic compromise, similarly may point you towards surgery. tandem stenosis, both cervical and lumbar spine, and then other high-risk activities that may lead to spinal cord injury, such as mountain biking or surfing. Options for non-operative treatment are somewhat limited. Gait and balance training can be helpful, preventing falls and additional injury. There's physical and occupational therapy that can work on paraspinal neck muscle strengthening. And then there's symptomatic treatments for pain, which may or may not be present, such as traction, epidural, and more physical therapy. Mobilization is a little controversial. There's some studies that show that it can help, especially in early disease, but I don't think that's being commonly used at this point. This was a prospective randomized control trial looking at 68 patients with mild disease and 3-year follow-up. They had both surgical and non-surgical groups. There were similar outcomes in both cohorts with respect to MJOA, the time 10-meter walk, ADL score, and then subjective patient assessment at 6, 12, 24, and 36 months. They found factors associated with conservative treatment being beneficial was greater AP diameter of the canal, a transverse area of the cord greater than 70 millimeters, ages 65, and then normal central motor conduction time. With respect to the safety of decompression, so basically is operative treatment beneficial and safe? This was a multi-center study of 278 patients with 1-year follow-up, about an even spread of mild, moderate, and severe disease. They found a significant improvement in MJOA score, NERC grade, NDI score, and SF36 with the operative cohort. The degree of improvement did not depend on severity of pre-op symptoms, except for MJOA, which you would expect as the bias. If you have a worse score pre-op, you have more room for improvement. And then surgical decompression was associated with improvement in functional disability-related and quality of life outcomes at 1 year. So this is important to remember that this is including the moderate and severe patients, so more than just the mild we were initially talking about. So that being said, is there a way to predict the amount of neurologic or functional recovery which can be expected? This was a study looking at 757 patients treated surgically. They were separated by MJOA of greater or worse than 16, and essentially was their cutoff for mild disease. There was 52% of patients achieving a score of greater than 16, whereas 47% still had residual disease with a score of less than 16. These percentages may be limited by the fact that older patients had severe myelopathy preoperatively, and their significant improvement didn't necessarily translate to a score reaching that 16 threshold. But the majority of patients, about 90%, improved to a score of at least 12, 10% unfortunately remaining below that level. They found associated with better outcomes of being younger, shorter duration of symptoms, non-smokers, and no gait or abnormalities. I think all of those make sense in context of the previous discussion. So very briefly, going to cover some surgical options. Traditionally, there's anterior approaches were preferred, especially with 1 or 2 segment pathology, and then posterior approaches were needed for 2 or more level disease. But in recent years, it's not necessarily as true anymore. Anterior and posterior techniques have been increasingly utilized for multi-segmental disease with similar outcomes. The advantage of an anterior approach is directly addressing the pathology, decompressing the central foraminal stenosis, and can aid in restoration of lordosis through the anterior column. Unfortunately, this can be difficult to address retrovertebral osteophytes without corpectomy or OPLL, which may limit access to the disease. And also increasing risk of dural injury. The posterior surgical options were, again, historically utilized for multi-level disease, especially in cases of congenital stenosis, but also older patients with advanced spondylosis and certain cases of OPLL. This relies on decompression through both direct removal if the more dorsal structure is the pathology, or indirectly by allowing spinal cord drift back. Typically, fixed kyphosis of greater than 13 degrees has been associated with unfavorable outcomes, especially posteriorly. Though this is somewhat controversial now, it depends again on the patient's specific pathology, as well as the K-line, which we'll go over next. The posterior approach is also typically associated with a higher rate of infection. So how do you decide anterior versus posterior? Because ultimately, this is a patient-specific decision. There's preoperative planning in general, which are things like the range of motion, how is their ability with extension, do you need fiber optic intubation, as well as a MAP goal of greater than 80 intraoperatively. more specifically with respect to the anatomy. There's cervical spine morphology, the number of segments involved, and the location and type of compression. There's sagittal alignment with a modified K-line, axial neck pain, and previous operations which may go into consideration. When assessing the sagittal alignment of the cervical spine, it's important to consider the posterior technique relies on the drift back of the thecal sac away from the ventral side of compression. The modified K line, which is the line connecting the midpoints of the spinal cord at C2 and C7, is a preoperative index that may predict if adequate posterior drift back will be achieved from anterior sites of compression. There's a regional kyphosis greater than 13 degrees, which has been associated with unfavorable outcomes. Sorry, give me 1 second.
Sorry, and he not seven here. It's weird.
Did we lose Mike again?
Sorry, give me 1 second. I just realized it's probably muted. Okay, can you guys hear me okay?
Yeah, now.
Okay, sorry, I got booted from my room and the thing was through there. So I'm not sure how much of that you guys heard, but you can read it on the slide. Very briefly, the anterior approach can directly address the pathology, lower infection rate, less blood loss. And then posteriorly, options are laminoplasty, laminectomy, and fusion can indirectly decompress by increased canal diameter, can maintain the motion through the posterior elements, which is important for range of motion, but also for avoiding pseudoarthrosis in patients with diabetes and chronic steroid use. This can provide the ability to address more than one level with congenital stenosis and similar rate of C5 nerve root palsy. The bottom is a pretty good example, multiple options and ways to do it. I think the one on the right is probably the most common that I've seen anyways, but provides indirect decompression from the canal diameter. Laminectomy infusion can be a good option, especially with multi-level disease and kyphosis of less than 10 degrees, or a correctable kyphotic deformity that can be corrected into better lordosis prior to fusion. This does involve removal of the posterior elements, therefore requiring stabilization to prevent post-laminectomy syndrome. And it can provide immediate stability and increase fusion rates. This may also improve neck pain with degenerative facets, which is a risk with laminoplasty due to the fact that you're not addressing that potential pathology. Combined approaches can also be utilized, especially with severe kyphosis or cervical deformity. It can provide additional spinal, and it can address spinal instability and poor bone quality in patients. And this can be a stage procedure as well. So there's a lot of studies that look at this. I mean, the short story for the rest of this talk is adequate decompression is the most important. The anterior versus posterior approach is very specific to the disease, so it's utilizing whichever tool is most appropriate depending on the patient's specific pathology. This was a meta-analysis comparing surgical approach showing no difference in neurologic recovery, though they did find that a definitive conclusion couldn't necessarily be made. 4 out of their 10 studies did have a higher post-op JOA with respect to the anterior approach, but 6 out of 10 did not. So they had a hard time drawing a definitive conclusion here. Interestingly enough, complication-free operation blood loss was higher anterior, which is kind of contradictory to other studies that I've seen, and a higher length of stay in posterior surgery. This study similarly looked at 8 level 3 retrospective cohort studies, systematic review at a spine in 2013, compared the effectiveness and complication profiles of anterior and posterior surgery. This same thing, they saw insufficient evidence for superiority of one versus the other. However, they did find a trend with dysphagia being lower in the posterior approach as expected, considering you're bypassing the ventral structures, and infection lower with anterior approach, similar C5 palsy rate. And they also recommended an individual approach. This was a multi-center prospective observational study, 264 patients, much more in the anterior versus posterior cohort, and they had about 85% follow-up at 1 month. Their outcomes were MGOA, neuric score, NDI, SF36, and complication rate. And once you adjusted for the baseline confounding factors, there's no difference between the two. Like I said, most important is adequate decompression. There's many guidelines that have been attempted to be made, but it really comes down to what you're trying to address. So is it kyphotic? Is it lordotic? Where does the K line fall? Do you need an anterior and posterior approach combined in order to address pathology at both locations? Is it congenital stenosis where doing a 1-level ACDF won't actually decompress other levels that have less subtle pathology? It's all patient-specific factors. Associated with surgery, complication profile is dysphagia, especially with the anterior approach. You can get other things like dysphonia, Horner syndrome, CSF leak, esophageal perforation, C5 palsy or an iatrogenic palsy, persistent neck pain, pseudoarthrosis, and infection. The persistent neck pain is particularly important when comparing laminoplasty to laminectomy and fusion, because with laminoplasty, like I mentioned, you're not addressing the facet joint, so it's important to get a CT scan. Similar to kind of a cervical disc arthroplasty, you really want to make sure that there's minimal disease and no preoperative axial neck pain. In conclusion, the guidelines for management from the AO spine is surgical intervention for moderate and severe. Like we talked about earlier, the more mild disease is a little bit more controversial. They recommend offering surgical intervention or a supervised trial of structured rehabilitation for patients. I think it's important to really counsel them in clinic. You know, this is a disease that not many people know about outside of spine surgery. So we really play a role in terms of guiding them through how this is typically seen over time with the natural history and what surgical options are and what those outcomes can help them achieve and not achieve too with respect to the stopping progression of the disease versus recovery. They suggest not offering prophylactic surgery in non-myelopathic patients without signs of or symptoms of radiculopathy, which I think we would all agree with, but is also something that's asked frequently in clinic. So that's all I have. Sorry about the change of location kind of mid-presentation, but hopefully it was useful in covering a pretty common but widespread disease that we see.
Thanks, Mike.
Thanks, Mike, for that review. Appreciate it.